Ladies and gentlemen, welcome to our next session. We're very pleased that we have so many online participants and so many faithful participants in the room, which I hope will join us in a moment. This session will be more focused on Poland and will show good practices concerning healthcare integration. This session will be kicked off by Professor Ewa Lech-Maranda, who will talk about improving care for hematological patients and will discuss the concept of a hematological network in Poland. Madam Professor, welcome. We have a very heated period despite the fall in terms of improving hematological care and its improvement in Poland. And I hand over to Madam Professor. We can see you on the screen, and I'm sure our online listeners can see you too. Ladies and gentlemen, good morning. Thank you, Madam Chair. Thank you for the invitation to participate in this conference. It's a great honor, but also an immense challenge. Thank you for the opportunity to present this topic. Ladies and gentlemen, hematology is a discipline that is developing dynamically. In Poland, just like in other countries, in Europe, we are witnessing a steady growth in demand for hematological services. This follows from increased incidence in blood cancer. Over the last 30 years, incidence has doubled. We can also see dynamic development of diagnostic methods, which help us detect blood cancers faster and effectively monitor blood cancer patients after treatment. But we can also witness a phenomenal development of treatment methods. They have not only improved the quality of life of patients and increased the number of remissions, but also have a prolonged survival free of progression of the disease. And those were achievements of the recent years, for example, B-specific antibodies or other therapies with the use of autological patient lymphocytes with an antigen receptor. And another important element here, which influences the increase in demand for medical services, not just in hematology, but in general, is increased public awareness about healthcare and the growing expectations of the public towards healthcare providers. Now let's look at the organizational situation in terms of hematological care in Poland. We have 48 hematological centers, of which 17 are hematological clinics, which operate at universities or research and scientific institutes, and 33 hematological wards. At the end of 2022, the total number of beds for hematological patients was just over 1,500. Among these hematological centers, we have 20 centers which transplant hematopoietic stem cells, HSCs, and 18 of those perform allogenic HSCTs transplants. And here we have 242 beds. The number of hematologists at the end of 2022, that was 579 active hematology specialists, which gives us a coefficient of 1.53 hematologists per 100,000 citizens. This is not a high result. The desirable results would be about 2.5 and 3 up to 3 hematologists per 100,000 citizens. Hematology is not a very popular domain selected by medical students or physicians who are graduating from medical universities. Luckily, in 2015, this specialty was introduced into the deficit specialty list, which made it possible to perform specialization training as residencies. And this increased interest of young physicians in this specialization. At the end of 2022, we had 265 training places which had been taken up by students or physicians. That's an increase by 155 as compared to 2019. But we still have about 100 vacancies, which means that the demand for young hematologists is still very high. What are the expectations concerning hematological care? Expectations of patients, first and foremost, but also the expectations of physicians and all those involved in providing health care. First expectation is to provide such conditions for health protection that will respond to current and the expected health needs which will emerge in the coming years. What do we understand by that? To improve accessibility to diagnostics and modern treatment methods. We know that diagnostics, the fast-track diagnostic pathway is not fully adjusted to the needs of diagnosing blood cancer. We are working intensely on this. I hope it will improve in the recent future. What I mean here is the DILO fast track in Poland. The standards are changing dynamically, therefore, in the area of diagnostics, we need to keep up. But we have to diagnose not just at the level of outpatient care, that is hematological centers, but also at the level of inpatient care. So at hematological wards, we have some very aggressive blood cancers, and diagnostics must be performed in hospitals and very swiftly. And here I have acute leukemias in mind. Another important issue is accessibility to modern treatment methods, and here I must express my gratitude for the Ministry of Health and the Polish HTA agency and many patients' organizations. I would like to thank for improving accessibility over the last 5 years. We have 30 new particle indications introduced over the last 5 years. Now we can say that Polish hematological patients have broad access to most modern therapies, which are also reimbursed in other European countries. Another important expectation, and that is what I will be talking about, is to introduce organizational solutions which will ensure comprehensive and coordinated, integrated hematological care based on cooperation between Polish hematological centers. And another element which you probably know more than me about is measuring effectiveness and treatment outcomes by the possibility of monitoring diagnostics and treatment in reference to structure, processes, and outcomes. And I hope that first the pilot project and then the full project of the National Hematological Network will respond to these expectations. The long-term objective is to improve detectability of blood and bone cancers and qualifying patients for therapies, and also decreasing mortality and prolonging 5-year survivals. This concept will be preceded by a pilot project, and this pilot project will be based on 2 pillars: coordination and comprehensiveness, and the second one is quality. How do we understand coordination? A proper coordination must start with specifying reference levels for different hematological centers. So assessing which center can provide which level of medical center, and this will be set forth on the basis of a center's capacity. We need vertical and horizontal coordination, so the right coordination within a hematological center and within the hierarchy of centers. We also need comprehensive hematological care. This is a broadly discussed topic because this disease affects mainly those with a median of 50 to 70 years of age. That means these are patients with other comorbidities. And modern health technologies also need to be monitored not just by hematologists but also by cardiologists, because most modern drugs have different levels of toxicity and other adverse effects than the traditional ones. Therefore, we need to provide comprehensive care. We need dietary support and other specialists to support our patients. So we need to introduce monitoring. First introduce therapeutic and diagnostic standards and then monitor them to optimize treatment outcome and improve the quality of provided medical services. Here we will introduce qualitative measures for the process and the outcomes, and eventually organizational qualitative measures, which will help us monitor the organization and functioning of hematological centers. Let me quickly describe the concept of the National Hematological Network, which will resemble the Polish Oncological Network. The center of this network will be the Center for Hematology and Transfusions. We will have primary, secondary, and tertiary levels. In each region, voivodeship of Poland, we will have a monitoring center. All of these units will cooperate with one another on the basis of cooperation and coordination agreements so as to provide coordinated care to patients. They will provide data necessary to monitor the quality of the diagnostic and treatment process, but also the functioning of the whole network. The data will be fed into an IT system and will then be sent to the National Health Fund. After a primary analysis, the data will be sent to the National Coordination Center, which will cooperate with the National Health Fund and perform an analysis together, then draft conclusions and forward them to the Ministry of Health. What are the main assumptions of the pilot program? First and foremost, introducing the assumptions for the reference model and verifying those assumptions. In the pilot project, referentiality will be based on the performance capacity of each center. So the workforce, the diagnose-related capacity and treatment capacity. After the pilot project, we will verify whether the assumptions we adopted are valid, and we will use them to improve all the qualitative measures that we adopted. On this basis, we will draft an organizational standard for hematological care. And the next step is to verify and test solutions, mainly IT solutions and organizational ones. We will do this based on an IT platform which will contain data on different measures and coefficients. It will also include data on the waiting times. This will help us improve coordination and quality of hematological care. This is an example of a referentiality model drafted based on the performance capacity. We will have different levels. One of them will be the tertiary level, highly specialist level. They will diagnose all types of blood cancers. They will have an intensive care unit, a daycare unit, and also an outpatient hematological center. They will be performing transplants, HSCT transplants and allo HSCT transplants. They will cooperate with other reference centers as part of the network. They will cooperate with specialist and primary hematological care centers. These first referential level, specialist care level, will provide medical services to selected types of blood cancers. They will not have the possibility of performing blood marrow transplants. The specialist level must have a hematological ward and also a daycare ward to ensure continuous care. They also need an outpatient clinic, and they will be obliged to cooperate on the basis of the signed agreements. And the primary hematological care level is a very dispersed level, but we wanted to describe it in terms of all aspects. We wanted to keep this primary care level in the network and to ensure cooperation with specialists and highly specialist levels. We wanted to elevate primary care to a higher level. This level will involve hematological clinics which can operate separately from hospital wards. We will have daycare wards which can operate separately or within a hospital, separate hospital beds in wards, in oncological or internal diseases wards. We know that we have such beds. We have wards or sub-wards for internal diseases or oncological diseases. So we want to map this situation and identify the available beds. We also want to establish cooperation at the regional level with primary care units to ensure consultations for these centers and improve the quality of primary care in these centers. And we want everything to be interconnected within the joint network. Another assumption is drafting recommendations for diagnostics and treatments within the pilot project for hematological centers. But these are some very specific recommendations which will help us identify critical points in this process and ensure completeness of this help. And we have included 7 cancers here, different types of leukemia, chronic lymphocyte, leukemias, and also lymphomas, among others, the Hodgkin's lymphoma. We decided to choose these 7 cancers because of their prevalence. They are very common. We know that some of them, another aspect is the clinical progress of these cancers. We also included aggressive cancers, but give a chance of survival, and also chronic lymphoma, for example, chronic lymphocytic leukemia. And also we addressed the age of the patients. Another assumption, which is additional to the main assumptions, is that while we will be drafting these standards for diagnostics and treatment standards, we will prepare guidelines for primary care physicians. This is not the main task or the main objective of the network. Still, we are aware that this is important, and I hope that we will be able to perform this in the next step. We need continuous and coordinated cooperation with primary care physicians. So as part of the pilot program and as part of drafting recommendations for hematological centers, we want to draft short clinical guidelines for primary care physicians, which will include indications for referrals to hematological clinics, indications for hospitalization in hematological wards, and some very practical guidelines. And we also want to draft a standard of chronic care for patients with hematological cancers in primary care, because we know that these patients need to be monitored effectively and need to receive effective treatment also at the primary care level. Sometimes the primary care physician can be the only one which is providing care to a hematological patient. In the future, we hope to conduct training for primary care physicians on the basis of the drafted standards for diagnostics and chronic care. The main assumption of the pilot is to introduce and test new settlement products. We've selected these products on the basis of certain gaps in diagnostic capacity and treatment capacity. We've also mapped and we want to map and test these processes. I've listed the most important ones. We focus on diagnosing infections in blood cancer patients. We want to draft a uniform diagnostic standard in all hematological centers by introducing these new products. Another very important issue is to introduce the treatment of serious infections with multi-resistant bacteria, also viral infections and others. We also need immunophenotype examinations of blood and blood marrow in order to diagnose and monitor MRD. Of course, we perform these tests, but we want to create new settlement products for these tests to make them the standard in all centers, in the same indications and in standard time intervals. Another element is the treatment of immunological complications, prevention and treatment of diseases of the central nervous system, and serological diagnostics. Here, extended phenotypes for red blood cells, among others, and specialist consultations for patients. So what I've been talking about before, comprehensive care for hematological patients, which extend beyond hematological treatment per se. And the last element, ICT consultations for the centers belonging to the network. And another element is monitoring the processes in the network. We have clinical indicators which cover the diagnostic and therapeutic process for specific cancers, but also indicators for coordinating patient pathways. And the second area are organizational measures which will help us define the effectiveness of coordination between centers within a region. We will use the number of consultations and therapeutic consiliums as our basis. We will also assess the waiting time for being admitted to a ward or advisory center. On this basis, we have developed qualitative measures of the diagnostic and treatment process and the coordination process. You can see that this has already been publicly consulted. We are working on the final shape of this project. The indicators will be limited as compared to what has been publicly consulted. We have the final number of indicators for specific cancers. In the case of some of them, for example, for acute lymphoblastic leukemia, We will provide therapy for the purpose of treatment or remission, and in patients who have already had 3 panels of diagnostic tests, that is immunophenotype, cytogenetic, and molecular tests. And the second indicator that we will take into account, the indicator which shows us whether we have the right coordination of care for a given patient. So the percentage of patients with diagnosed acute lymphoblastic leukemia which have been qualified for treatment by a therapeutic team and for whom a hematological treatment plan has been prepared, or who has been disqualified from treatment within 7 days from the diagnosis. And we also have indicators for the Hodgkin's lymphoma. We will monitor the beneficiaries of the medical services who have received the PET-TC treatment before introducing first-line treatment, and the percentage of patients with Hodgkin's lymphoma who have received histopathological tests. What we will look at is the percentage of full remission, progression-free survival, and full survival. We also have measures for the pilot program. The number of measures will be limited to 12. We will measure general aspects of the pilot program, also organizational ones, coordination, and clinical aspects. Here are some examples of the indicators that we will use: the number of patients involved in the pilot program, the number of multi-specialist consultations per 1 patient in total, and the number of medical advice and telephone consultations. Here I gave the example of a regional coordination center for a highly specialist and primary reference centers in a given region as part of the pilot project. And the desired effects that we want to achieve is providing health protection in hematological care by improving accessibility to diagnostics and treatment of blood cancers, shortening the waiting time for these elements, higher detectability, and the right qualification for treatment. As a result, we hope this will help us increase the diagnosis, the detection of these diseases, and as a result, reducing mortality and prolonging 5-year survivals.
Thank you so much. The professor will stay with us, so we have we have time for questions to the professor. Do we have any questions from the room? Well, I have 2 questions actually. I'm still waiting for the answer whether we have some questions sent on via the chat. But first, my question: because the network assumptions are quite elaborate, from the perspective of treatment standards, apart from looking at the what would you say is novel in terms of digitization or measurements? Are there any innovations which gives us the hope for a more broad development of hematological care? Well, there are actually a lot of new things. It depends on the areas that we look at. Definitely coordination will be a novelty, coordination between the centers. Also, the standardized comprehensive aspect of the care, but the greatest novelty, and this will apply to all the networks that are introduced, it's monitoring of results, monitoring of processes. So quality monitoring, understood in the broad sense, as ensuring the quality of treatment processes and the quality of functioning of the centers. So the novel tool that will be used for that, and without which this monitoring would not be possible, is the creation of an analytical and IT system for data collection and data analysis. That will definitely be a novelty to us, because in our everyday practice, we don't actually monitor, we don't map those processes. So we will gain a huge resource of knowledge on how we function and what can be improved for patients with specific cancers, how improvements can be introduced in terms of access to diagnostic tools and with regards to treatment standards. And I can see we have a question from the audience.
Dzień dobry, Robert Łukowski, Keynote. Ja od jakiegoś czasu mam przyjemność zajmowania się właśnie takimi narzędziami do zbierania danych. To oczywiście jest trudne, bo z jednej strony wiadomo, że personel medyczny jest obciążony
administrative tasks, and on the other hand, we'd like to collect as much data as possible. So it's great that you want to use dedicated tools. We have experience from different networks where such indicators are collected. But if we start collecting that data, that's just the first step. What are the plans for expanding this scope of indicators? Because technology will definitely help here. We are working on collecting data in a way which does not burden the doctors, but how do you see further development from the perspective of what data can be collected and how it can be used once we start the actions on a systemic level?
Thank you so much for this question. As concerns the scope of data gathered, I must say that in the project that was submitted for public consultation, we had many more indicators. I wanted to map all the possible elements, all the important elements, those which were relevant to the quality of diagnostics and treatment. However, we need to limit the number of indicators so that they correspond to our capacity. But the first step that we will do is analyze what we've managed to select. We will look at the daily work of hematological centers and define the level of care that we want to achieve. There's certainly room for improvement here, and that will be the point where we can reflect on monitoring any additional aspects. Of course, a pilot project cannot cover all the relevant issues. As concerns the transfer of data and the reporting done by hematological centers, it's an important question. To me, the perfect model for the future is one where the system compiling data and an IT and analytical system is plugged into the hospital medical systems. That's the perfect solution. But we know what stage we are at. We know there's a long way ahead of us. Still, we know that every person involved in supervising and managing, cooperating or supervisory institutions in healthcare should strive to achieve such a goal. That would be the perfect situation. In order for that to happen, apart from the whole analytical and IT resources, we need to standardize, harmonize our medical documentation. I didn't mention this element. However, we will be taking this into account when drafting our diagnostic and treatment standards. We want to introduce some rules. I don't want to say that we want to introduce a template or form, but certain rules for inputting the data to make reporting easier. That's one more important element. I hope that in the national pilot of the Polish Hematological Network, we will not report on the indicators, but on the data used for the indicators. For each indicator, we have a strict definition, so what we have in each part of the formula used to calculate it. And these definitions will be an integral part of our standards for the centers participating in the pilot. We want to avoid certain errors that could be made if hematological centers report only the final product, so the indicator. Everyone can understand certain things differently. Therefore, we think it's better to report the data used for calculating indicators. And we want to ensure that they are correctly calculated and introduced to the system once they are verified. If we could dive deeper into this, we have some technological solutions, we have interoperability. It follows, however, from our experience that very often, once we have a defined core data set, so the data we want to gather, this is a foundation for collecting data for the purpose of a given project, for reaching a specific objective, but also for other projects. So my question was driving at whether these data will be available for other purposes, not just for calculating these indicators, especially that you're collecting these raw data. The data that will be reported as part of the pilot project will be, of course, broader than the data necessary for calculating the indicators, because we want to evaluate the pilot project and draw conclusions for the network. It is my opinion. I'm sorry, I can't see you, so it's difficult to give a reply and establish some eye contact. These data are public data for the public payer, for the Ministry of Health, for the Polish HTA agency. Therefore, a well-constructed database which collects the relevant data may become a very important source for a wide range of analyses. The Polish HTA agency can make use of those data, and clinicians, and the National Health Fund. That is my opinion, that is my position, and I hope it's congruent with yours. Thank you very much for this answer. We have one more question. Yes, please go ahead. Joanna Turkiewicz, National Center for Oncology. Madam Professor, you've shown us a lot of indicators, but are you planning on any indicators for measuring patient experience? You want to improve the process, you want to improve the quality, but do you want to include the patient perspective and analyze patient experience? Yes, of course. I did not show this in our presentation, but we will do a survey analyzing patient satisfaction and gathering patient opinions. I did not include it in the presentation, but yes, of course, it's an important part of our pilot project. As Madam Professor has said, and as I understand this will be a central system gathering data for the whole process. The indicators will be calculated at a central level. So these centers do not have to analyze the data, they just gather it. That will be performed on a central level. And we also have what is included in legal regulations, patient surveys and elements reaching beyond the standards. Everything has to comply with the obligatory regulations. You also conduct additional analyses to go more in depth in the case of the indications listed in the presentation, as I understand. Thank you, Madam Professor. I'm very pleased that you presented something so novel to us, something so new in the Polish system. We hope that no matter how the elections turned out, this will be introduced to the system. I hope that public consultations were fruitful and that the Ministry of Health, irrespective of any political changes, will remain willing to introduce this concept. And I invite Madam Professor to participate in other sessions of ours. Thank you.
Ladies and gentlemen, moving to the next presentation, Professor Hryniewiecki. He will present the assumptions of the National Cardiological Program. He will present experiences from the last 2 years. We have a video recording. Unfortunately, he was not able to appear in person. It's because of the hot pre-election period. So now I would like to invite you to listen to our next presentation regarding the cardiovascular program. An ongoing pilot project which supplements the entire national cardiology network. I hope we will be able to see the assumptions for the whole cardiological strategy. Hello, ladies and gentlemen. Thank you for inviting me. I was asked to talk about forms of coordinated care, about improving care in the area of cardiology. And that can be done by the National Cardiological Network, which has been functioning as a pilot project for the last 2 years. And the National Cardiology Network is a part of a larger program, the National Cardiovascular Program, which was launched at the beginning of this year. Why was the Cardiology Network, which is a part of a larger program, was launched before the whole program? We decided we cannot wait for the whole large program to be launched because the situation in the cardiology care is difficult, especially in the post-pandemic times. The waiting times for cardiology consultations are greater, so we had to do something quickly. That's why we launched the program first in the Mazovian province and then in subsequent provinces. But I will get to that in a moment. On the National Cardiovascular Program, I would like to say a few words. It is a comprehensive shift in the approach to treating these disorders, but we'll get to that in due time. First, starting with the National Cardiology Network. It was started with the regulation of the Ministry of Health, dated 10th of May 2021. At that time, it was a pilot project for the Mazovian province. This year, starting 1st of April, we have added 6 more provinces that you can see here on the map. And currently, the pilot project is being carried out in all 7 provinces. The main assumptions of the pilot project were to speed up diagnostics and speed up making a diagnosis in specialized centers, resulting from the assumption that the sooner the patient is diagnosed, the sooner the right treatment is proposed, the better the effects. It should be mostly a tool for the primary healthcare physicians, but not just for them. We also saw modifications of the regulations in the course of the pilot project. We have expanded the scope of the entities which can refer patients to the cardiology network. Why? because we decided that modern diagnostics and treatment should be something provided to patients, also cardiologists far away from the large centers, so in smaller towns. Also patients who end up in hospital wards, which are not close to the main centers. All those patients should have equal access to a speedy specialized diagnostics and treatment. So, best treatment, best facilities. Cardiology is changing in that way that treatment is often based on very complex, advanced methods, and that is possible only in the most specialized centers with the most experience. It can be both. We're talking about both the facility in general and the people working there. Also, diagnostics is becoming more and more complex, and to a large degree needs to be carried out in the highly specialized center. It also involves information for doctors and patients. Obviously, it's essential. We can't just issue a referral and assume that the patient waits idly for the subsequent stages of treatment without knowing what will happen and when. During that time, the patient's condition might deteriorate. The referral mode might change, and the patient might require a more urgent hospitalization. So we need a full set of information of where the patient is in the system. The patient needs to be informed of when his next visit will be. And in the case of any doubts, the patient needs to be in contact with the cardiology care coordinator. This is something which is used also in other programs like in cancer care. And patients always perceive it as a good thing. They feel like they are not lost in the system. So this increases the patient's safety and also the confidence of the doctor who is in charge of the patient's treatment. The objective of the pilot program, it is determined for a specific time frame. We have shifted the deadlines as we added additional provinces. We'll probably not be waiting for the full-scale implementation of the program before we evaluate the program. Before that, we'll probably be offering this care to all types of patients. That was the recommendation of the Ministry of Health, that the act on the National Cardiology Network be prepared, and probably next year this act will enter into force, which will make the National Cardiology Network available to all patients across Poland. The cardiology network was also submitted as a milestone as part of the National Recovery Program. This is a short overview of the structure of the cardiology network. Obviously, the referring facilities include also outpatient care, specialized outpatient care. The most advanced procedures are on the second level. The second and third level differ in the region, and all that is supervised by the National Institute of Cardiology, but they are mostly in charge of the statistical aspects and keeping track of that. All that is done using a computer system that I will discuss later on, because various databases are a part of this supervision. And the National Institute of Cardiology obviously also offers certain services, provided that those services are not available on the regional level. That includes also heart transplants. It is also worth mentioning that in the structure we have singled out not just hospital wards but also outpatient clinics, because outpatient clinics are an important aspect. We should put emphasis on outpatient care, especially in hospital outpatient clinics, because we assume that hospital outpatient clinics have access to a full background in terms of treatment and diagnostics. Sometimes a hospital stay is not necessary to take care of the patient. So far we have proposed 4 different pathways: arrhythmias and conduction disorders, heart valve defects, heart failure, and resistant and secondary hypertension. So hypertension, which requires more in-depth diagnostics at least once in a lifetime of the patient. Why did we choose those 4 pathways? Why do they not include coronary diseases, which are the primary reason of fatalities in patients? It's because when it comes to acute myocardial infarction, treatment is provided on a good level. It's something that we boast with internationally. So coronary diseases and myocardial infarctions are well taken care of. Also, there was a problem with the post-infarction period, but we also have COSAVO program, which is the comprehensive MI specialized care. It is available for all facilities. Unfortunately, not all facilities have joined the program. So as the national consultant, I want to declare that starting January next year, joining this COSAVO program will be obligatory for all facilities, which means that all patients will have access to this program. So we have those 4 pathways that I just mentioned. And we assume that this is not a closed-end list. We'll probably be adding additional pathways in the future. I would like the cardiology network to be flexible, to allow for adding additional groups of diagnosis. I would like it to be possible to modify specific mechanisms applicable in the network. For example, I would like to be able to increase the scope of care for post-hospitalized patients. This is an example of one pathway regarding one of the ones. You can see a detailed description of all elements of diagnostics and treatment using such solutions like the heart team. We use all possible options available in modern medicine. Everything is well described in detail to facilitate a patient's road towards the right treatment. The key element of the program is that the cardiologist serves as a consultant. So he is not the doctor in charge of the whole treatment pathway. So to shorten the waiting times, the cardiologist should diagnose the patient and place him on the further path of treatment. Only patients in special situations should stay with the cardiologist. Most of patients should return with a diagnosis to a GP who will provide regular care to those patients. Otherwise, the waiting times will continue to be long, even though the number of our cardiologists per patient is greater than the European average. For that pathway to be safe, obviously we use an IT system which tracks the patient's pathway across the system. It is a clear, easy system. It can be also used as an onlay to an existing IT system in force in a specific facility. We provide information. There is a cardiological hotline. It provides information for patients and for healthcare providers. This is an important aspect of that system. Right now we have over 15,000 patients covered by this pilot project. This group has been increasing rapidly after we added 6 new provinces. Unfortunately, the main facilities that refer patients to this network are outpatient specialists and GPs don't do it often enough. We hope this will change. Those programs are not competitive, the program of the entrusted budget and this program. They are complementary. So and this can also be a way of referring the patient to the cardiological network. So there is a broad way of using the resources of the National Cardiology Network, and I can wholeheartedly encourage GPs to do so. When it comes to the specific pathways, the conduction disorders are the ones that are used most often. The average time for qualifying to the program is 30 days or less. Let's hope it stays that way. We offer full information, comprehensive information, and this is the basis of the cardiology network. It should be made available to all patients with cardiovascular diseases, and that's something we provide. So this network involves rapid diagnostics, a tool for GPs who otherwise don't have the tool for referring patients. Now they do, and we also want patients after a diagnosis to return to the GP. We insist on providing the best care, the best services, services such as transcatheter procedures, aortic valve implantation, mitral valvoplasty. All those services are provided without any limits. Increasing the role of hospital outpatient clinics, the cardiologists serving the role as a consultant, providing information to doctors and patients. That's the emphasis of the program. And now I will talk a little about the cardiovascular program, because like I said, the cardiology network is just one element of the larger program. The program, adopted by the Council of Ministers in December 2020, almost 3 billion Polish zloty to be invested in the years 2020-2032 to invest in the personnel, in education and prevention, which is still an undervalued and omitted topic. All that is to change. Currently, we are a country characterized by a high cardiovascular risk. We want to change that situation. We want to catch up with the European countries where the situation is better. We need a program like that. Currently, there are 2 programs in Europe. It turned out that parallelly we were carrying out works in Poland, and works in Spain also were carried out. turned out that overworks were carried out without cooperation. The conclusions in both countries, in Poland and in Spain, are very similar. There is also a recommendation of the European Society of Cardiology. They recommend that similar programs are introduced in all countries, so we are ahead in comparison with other countries. We have secured funds, and we are free to introduce changes which can cover all aspects of cardiological care. This indeed is a huge task. It is a big program, and all that to reduce the incidence of cardiovascular diseases and to provide equal access to patients across Poland, because right now there are huge discrepancies between access to specialized care depending on where the patient lives in Poland. We know that in some places it is difficult to access a cardiology. I'm not sure if it will be possible to convince cardiologists to work in smaller cities. Even if we are not able to do it, we have to provide a way for patients to have access to best care, regardless of where they live. We also have to improve the organization and collaboration with international facilities. What I'm presenting right now is an example of some of the actions that are planned for this year. Because this program is so comprehensive, I would not be able to present everything, but I would like to highlight what we will be doing this year. First of all, the so-called Wobaśni card. We need statistical and epidemiological data. This is an epidemiological study, a multi-center national population health survey regarding cardiovascular diseases. It covers health behaviors, risk factors. The first survey was carried out in the National Institute of Cardiology. We are referring to that first survey, but we want to do it on a regular basis. We want to keep track of how the health behaviors and other factors change over time. We will also be creating a system of biobanks. We are currently creating the first biobank in the National Cardiology Institute. This is again the epidemiological study I mentioned a moment ago. This is the study which for the first time is not just a typical epidemiological study, but it involves the elements of blood tests and genetic testing. So it will be a unique study in the scale of the country. Another action plan for this year is the system diagnosis, so a kind of stock taking of our available resources in healthcare, particularly with regard to cardiac care. What wards, clinics we have, what personnel we have, what equipment we have. So we have to do this stock taking of available resources so that we know what changes should be introduced. Prevention, that's also very important. The programs should be planned for many years. They can be effective only if they are planned for a longer time horizon. We want to address children, we want to address the youth, and to reach adults that way as well. I think addressing the younger people might be more effective. The previous programs have been not long enough. Their efficacy was not sufficient. And also diagnostic and therapeutic standards. This is a new concept in medicine in Poland, particularly in cardiovascular diseases. So short rules of carrying out diagnostics and therapeutic aspects in Poland, created on the basis of clinical guidelines created by specific associations. They are to be concise, and they are that way supposed to be more available. We are using the example of solutions in place in the UK, where NICE prepares similar therapeutic standards. We already have several groups of experts who are selected for the creation of those standards. We will start with standards in treatment of hyperlipidemia. Also, cardiac rehabilitation is something that requires quick changes. So we have to introduce therapeutic standards as well. Right now, there's a work undergoing on what we have in place right now. We know that access to cardiological rehabilitation is not equal across Poland. We also know that the care for cardiac rehabilitation in pediatric patients is in poor conditions. Registries, we want them to be universal tools, which allows us to create new such tools. Without data from the clinical practice, we cannot suggest good solutions. This data is crucial to change the system in a reliable way. And investments. The program is focused on innovations, on new aspects, but we have to bear in mind, but we have to maintain also the regular options that we have. So we don't have to create new facilities, but we have to maintain the resources and the capacities of the current facilities. So that was a short overview of the National Cardiology Network and Cardiovascular Program. Thank you so much for your time.
Thank you. Unfortunately, we don't have the opportunity to ask questions because Mr. Professor is not present here. You can forward the questions to me and I can ask them to the professor and then give you some feedback. This session is a hybrid session. We also have recordings because some of our participants could not participate neither online nor in person. Now I would like to give you my lecture on cancer care coordination. I want to tell you about a project that we implemented last year. We worked with patients with the Coalition of Cancer Patients in the Lower Silesian Oncological, Hematological and Pulmonological Center. We did that as HTA Consulting and we got a global grant for that. In a month, I am going to London to present the results of that grant. We drafted a report which has been put up on our website, PKPO. We've also conducted research on Poland's experience, on Polish patients' experience in oncological treatment and how a coordination or integrated care impacts their experience. Let me give you this report. We have Maria Libura, one of the co-authors of the report. The project lasted over a year. It was very ambitious. For the first time, we adopted a comprehensive approach to coordination. We did a literature review. We also tried to delve deeper into systemic needs concerning coordination and integration. The whole report was being worked on just before the oncological network was introduced. And once that happened, some things became obvious. I hope that in some time, we can measure new experiences. During the project, we validated a certain tool. We are just finishing off the tool, the publication on that tool. We have Joanna Turkiewicz with us, who also participated in the project. The project involved an appropriate validation of the tool. It was performed in Polish on a sample size of 500 oncological patients. These patients evaluated the tool, then we gathered the data and validated it. I hope the publication will come soon. At the moment, work is pending on finalizing the submission of this document. Moving on to the project itself. Let me show you some of the most important aspects. We had very tight cooperation with Polish centers, with oncological ones. Mainly, we worked with female coordinators because it's mainly women who coordinate oncological care. What's interesting is that this was a new experience for us. That's because coordination in Poland is understood mainly as the presence of coordinators. Well, that's not true. We have different tools, among others, coordinators. So we looked at coordination and the tasks of coordinators. And these were different depending on the center. There were no harmonized tools for coordinators. In Poland, we are currently working on the whole system of thinking about coordination. In a moment, you've just heard about the hematological and cardiac network. They've been drawing from oncological experience. Professor Hrnewiecki told me before this presentation that they drew from oncological experience, but they want to go one step further to diminish the chaos in the system despite the introduction of new tools. I invite you to my presentation, ladies and gentlemen. I'll tell you about the report itself, what we managed to create, and the project itself. What was important was that starting from 2015, with the introduction of the fast-track oncological treatment, we were trying to improve its quality. Now we want to create an electronic form of that. The Ministry of Health is working on that. This is supposed to improve communication between different stakeholders. So we have a plan for diagnostics and treatment. Let me emphasize that. In the electronic fast-track oncological card, we will have information about the patient. We will have an act introduced on the possibility of transferring, sharing information. This is the first step to improve integrated care. We had problems with the flow of information between different stakeholders in the system. The introduction of coordinators and the fast-track procedure and the obligation to integrate care was supposed to improve communication. If we don't have an automated system for transferring data and evaluating these patient pathways, we need coordinators to do that, to coordinate patient pathways. This was a novel function. We did not have anything of the sort in the system. We did not have coordinators. So please imagine suddenly between the physicians, the nurses, and all the medical staff, we have a coordinator who is trying to lead this process. I don't envy coordinators. It's a very difficult role. You have to communicate with so many different professionals with their own medical habits concerning treatment, diagnosis, but also creating medical documentation. This is a challenge. The lack of coordination before the introduction of the fast-track procedure caused dissatisfaction in patients. Some patients took over some of the communication tasks to fill in the gap. Coordinators improved communication within a center, but it did not resolve a problem present in Poland, that is the flow of information between different centers. And that's what we tried to do in the pilot. That's what we looked at. We wanted to see if coordination, which is not a goal in itself, it's a means for creating integrated care. So we were looking at coordination and looking at all the tools, harmonization, monitoring, the fast-track procedure. The fast-track procedure was also monitored in our pilot project. Every center participating in the pilot created its own tools. Wrocław created a communication system called POS for communicating with physicians to fast-track patients from primary care to hospitals. In Lower Silesia, we had tools for supporting cooperation between different centers. If a patient didn't want to receive treatment in Lower Silesia, he could or she could seek care in a different center. for example, higher level of care. So you can see how we monitored patients, the entry of patients into the system. What's interesting is in Poland, this applies mainly to the first stages of the patient pathways, diagnosis, radiotherapy, etc. But what was missing in our pilot and in the oncological reform is including palliative care. When we look at the definitions, that coordination and integration, understood as natural flow of information from the patient, and also the role of the coordinator should lead the patient at every step of the way. And the patient shouldn't be worried about ending up at the right place. The patient should just be taken there by the whole process. So we're focusing on the patient pathway, but also at communication between different centers at different levels of reference. In the highest levels, we have the greatest delays, which are a result of the long waiting times and queues. We had some workshops with patients during this project. What was emphasized is that patients need human support, not just receiving a diagnosis, a referral, go there, do this. They need human contact, limiting contact with physicians and nurses who do not have much time, lead to a situation that patients need improvement in this area. They need to feel a human approach. And here the coordinators took up that role and provided a human touch to the process. When we looked at the integration taking place, it was not until the National Oncological Network was introduced that we had some national integration, but we're at the very beginning of this path. The introduction of the electronic fast-track procedure will start integrating this whole process. We have some communication between coordinators, but we have some organizational challenges. We have integration at so many levels: clinical, professional, organizational, systemic. And we're starting to delve deeper into the concept of integration at all of these stages. But we're also thinking about how this improves care. When we look at that, we look at the consumption of resources, and we also look at the costs, the main challenges in the system. We're starting to look at population health. We had some indicators in the pilot project to see what we are capable of achieving. What is missing, and what we think that satisfaction does not fully correspond to experience. Globally, we're moving away from satisfaction surveys. We're looking at patient expectations and whether these were fulfilled. A patient can be satisfied although they receive poor quality care because they don't have the sufficient knowledge. And experience tells us what really happened. Therefore, the survey we conducted helped us assess patient experience. We wanted to see if care is coordinated, but we also wanted to say if this care is actually patient-centered. Sorry, I can't switch through my slides. I have a definition of coordination here. It should be a coherent process, and we should have a coherent coordination system. This has been showed by global research. This is set forth in the publication. This helps with the timeliness of treatment. It improves the costs. Even if we have a new element such as a coordinator, they are an improving factor. They increase the cost effectiveness and the consumption of resources. If we analyze the costs of different progress stages of cancers, we can see that these costs are increasing logarithmically. So the costs for coordination are relatively higher, but the benefits are much larger. Coordination improves the patient comfort. A well-oriented patient who knows what they should be on the lookout for, what symptoms, when they should react, what responses from the system they can get, and what safeguards they can use on their own, gives a sense of security to the patients and also gives a sense of stability and a possibility of communicating where we don't need alerts or warning signals. This improves the quality of life, the comfort of patients. This gives us an opportunity to engage in calm and soothing communication. So improving the flow of information, improving the communication process. We think that coordination is communication, integration is digital, human, interpersonal communication, and also any other communication methods. Dona Bedian, who defined certain terms already in 1966, said that this is about continuity, interpersonal treatment, information, organizational continuity. When we say continuity, we mean channels of communication. The dimensions of coordination. We can talk about horizontal, vertical, systemic, organizational, medical staff coordination, functional and normative, and clinical as well. We have the Polish law on the oncological network. I don't know if you've read it, but the coordinators have just submitted a proposal for making them a new medical profession. I believe that's a function in the medical system. You can have a nurse, an administrative staff member, and all of them can be coordinators. That's open to debate. However, we have different solutions across the globe. We're at the very beginning of this pathway, and we still have some time to think about the direction we want to take. Let's look at the dimensions of cooperation. In the western part of the world, coordinators are often physicians who supervise the whole process. This is called clinical coordination. We have organizational supervision, and that's what we can see happening in Poland. Some organizational coordination with clinical elements, because the female coordinators also have some knowledge, some medical knowledge, and knowledge about processes supporting patients. But this is still an ongoing discussion. A coordinator is not tantamount to coordination. In different countries, we have different solutions. Everything depends on the available resources and also the objectives we want to achieve. And let's move on to our survey. We had 515 patients, 5 centers. Very quickly, we conducted surveys targeted at patients. We looked for patients who received treatment recently. But as you can see, the diagnosis could have been received in different periods. 70% received their diagnosis in the given year, in the year of the survey. This means we monitored the experience of fresh patients, and in the case of the remaining 30%, we looked at past experiences. We asked the question, how frequently do you receive useful information about your health at the right time? The key phrase here is at the right time. Sometimes we receive information, but it's too late and we can't respond accordingly. Look at the graph here. Over 70% received the information always or at the right time. 30% needed improvement in terms of communication. At this point, we're not asking who needs more communication or who can provide it. The information can come from the physician, nurse, or coordinator. There's a lot of possible sources. When we look at the forms of care and whether they are coordinated, almost 90% of patients answered rather yes. Here we should additionally look into appropriate forms of care. These could be incompliant with standards. Patients cannot evaluate that. For that we need separate tools. So that's the responses of the patients. And another question was, were you involved in the decision-making process to a satisfactory level? A large part of the patients, more than 70%, was involved had the opportunity to become involved in the process. Support for patients from the entire medical staff necessary to take care of one's own health and well-being. Almost 70% answered to a large degree. 30% responded that they receive unsatisfactory information. The information is not sufficient for them to take care of their own health and well-being. This is mainly information that the patient takes home, not just they receive care in the treatment center. This is about information that patients need after they leave. The next question: did the medical staff involve your family or closest ones in decisions concerning your care and treatment? Less than 30% responded to a certain degree. We need to improve standards on involving families and closest ones. We have to ask ourselves whether the model used in Poland is the appropriate one. We have to think about how we can provide patients with a support system. Oncological patients, especially in advanced stages, require more and more support from the people accompanying them. It's not just family, but also other people. You can look up all the results in our full report. So this is just a snapshot. What patients pointed to was the need to reduce waiting times, the need to provide support and information about where they should go to seek medical advice, so that patients don't have to look for it on their own. They even said that they need crisis support from coordinators. This points to a great need for mental support. At the initial stages, patients do not know they will need psychological support. They're not aware of that. This is a problem with the level of awareness in our society. Therefore, they seek such support when they reach crisis, and we should prevent them reaching that stage. Our patients responded that psychological support is important for them. They also need the fulfillment of their associated needs, for example, the help of a dietitian or access to rehabilitation. They need some additional information, not just about the illness. Now, expectations and experiences of our patients showed us that we need to provide more family support, mental support. We need to increase the levels of empathy. For the first time, empathy became a keyword in our survey. It's more important than professional competence. The coordinator must be capable of empathy. And this means that professional training is as key as the human touch to communicating with patients. The recommendations: improving different areas of care, but what I want to underline is to create a system for educating coordinators. This has been emphasized that this system is dispersed, it is not harmonized. There's also the issue of certification, creating teams of coordinators. It was emphasized that coordinators should not be one profession. We need physical therapists and nurses, dietitians. We need a wide range of medical professionals who take on the function of coordinators. This is an interesting experience because as we talk with coordinators in different areas, we hear that this function is very interdisciplinary. This could help improve some of the missing links in healthcare. And one more thing I want to point out to you, ladies and gentlemen, is introducing tools that coordinators can use. In in-depth interviews with coordinators, this came up quite often. Coordinators feel that they are on their own. They have to come up with their own tools. They don't have contact with all of the aspects of medical documentation. They don't understand certain issues. On the one hand, we need training, but we also need uniform procedures and standards for documentation. It's not just about taking calls, but also organizing the patient pathway. As this has been left at the discretion of the service providers, we need to work on this, we need to share experience, we need to show good practices and tools. That's the direction we need to be going in and where we need development. I'm awaiting the publication of the report. I hope that the questionnaire will help out in further research to show what changed in between our survey and present day. Our research also highlighted that coordination was slightly better in the pilot than outside of the pilot project. The pilot project provided better circumstances, a better environment for coordination and for patient-centered care. This shows that if we focus on certain solutions, can point us in the right direction. We're at the beginning of this journey. I hope that the oncological network, ladies and gentlemen, Via Ortwijn from the Netherlands is not here with us. She's one of the senior researchers in HTA. That's 20 years of experience. Via is a very experienced HTA analyst. She participates in many projects. She's working for the medical center in Nijmegen University in the Netherlands. And she's focused on scientific activity. She conducted many projects in the EU, but also across the globe. China, Kazakhstan, UAE, Canada, so many countries. I invited Via because she deals with a new HTA trend. She looks at integrated HTA for assessing complex technologies. Those can be systemic solutions, whole procedural pathways. HTA is starting to assess elements of the system and solutions. Ladies and gentlemen, I hope you enjoy the next presentation on integrated health technology assessment for evaluating complex technologies.
Ladies and gentlemen, my name is Via Ortwijn and I am the senior researcher at the Radboud University Medical Center, and I'm based in the Netherlands. And first of all, I would like to congratulate the organizers of the conference with their 18th already anniversary and with a very exciting program. And second, I would like to say that I'm very sorry that I can't be with you during the conference due to traveling. And I'm therefore very grateful for the organizers to share my presentation via video. The organizers have asked me to provide my perspective and my experience with integrated assessments of health technology and especially of evaluating complex health technologies. My presentation is mainly based on the concepts and methods that we developed in the Integrate HTA project, as well as its successor Validate, which is an acronym for Values in Doing Assessments of Healthcare Technologies. And we also applied the Validate project in practice. I also would like to note that the handbook, as well as the Integrate HTA guidances on how to conduct integrated assessments of complex technologies are freely available as a PDF file at our project website, which you can see on this slide. I also would like to acknowledge all my colleagues from both universities and HTA agencies that were involved in both projects, and especially the Validate project that we concluded by the end of last year. So coming back to what health technology assessment is about. So here you can see the definition of health technology assessment. And especially health technology assessment is about determining the value of a health technology at different points in its life cycle. So it is about identifying the intended but also the unintended consequences of using a health technology in practice. The overall value of what we mean by value or how we determine value varies depending on the perspective that is taken, the stakeholders involved, but also the decision context. For example, whether you focus on a national healthcare level or a hospital level. And I will come back to that later during my presentation. So, like I said, that HTA is focusing on the comprehensive studies of implications of health technology. Since its beginning, the focus has been often on this broader perspective of consequences, but during the years, the focus has been shifted towards, or narrowed actually, to issues of affordability. Assuming that the budget for healthcare is limited and that technology is the main cost driver in healthcare, HTA is often reduced to answering questions like, is this technology effective? Is it safe? And does it provide value for money? Although answering these questions might be necessary, it may not cover the broad range of issues and concerns that are raised by health technologies and that need to be addressed by decision makers. And these could include: what is the value of specific innovations? What impact do they have on clinical practice, on population health, and social development? Although the importance of these questions is recognized, in current practice of HTA, these questions are often neglected, or they are assessed separately as what people tend to think are ethical and legal social issues. This distinction between different types of analysis suggests that there are different ways of studying a health technology: through empirical research, studying the safety, clinical, and cost effectiveness, and through normative inquiry, studying the ethical, legal, and social implication. As a result of this, health technologies and the practices that are created by them seem to be completely distinct from moral values. It is as if they occur in completely separate, mutually inaccessible domains, being divided between what we call a neutral domain, facts about consequences of a health technology, and value-laden domain, about the desirability or the undesirability of health technologies. By having this distinction between the two ways of analysis, it may neglect that health technologies have both an empirical and a normative dimension, and this separation may lead to conflicting results that can impact the uptake of health technologies in practice. And I will show you an example of this. The example is non-invasive prenatal testing, or in short, NIPT. NIPT is an example of a health technology that may be used in many different ways and therefore also raises different ideas about its desirability. In recent years, NIPT has rapidly transformed the prenatal screening landscape. Following the discovery of cell-free fetal DNA, NIPT was introduced in clinical practice in 2011 and became increasingly available to pregnant women worldwide. NIPT is a prenatal screening procedure that analyzes cell-free fetal DNA, which circulates in the mother's blood during pregnancy in order to obtain information about the fetal genotype. Because only a blood sample of the mother is needed, the procedure does not pose any additional risk of a miscarriage that are associated with the available invasive test. Besides this reduction in risk of procedure-related miscarriage, it also has other potential advantages. It can be performed relatively early during pregnancy, around the 10th week of pregnancy. It could have a higher reliability than existing tests and could potentially be used to analyze the entire fetal genome, which provides the option of detecting conditions which no other screening protocol exists. In implementing NIPT or NIPT, countries make many different decisions with respect to whether it's offered commercially or as part of a national screening program, and whether it is offered to all pregnant women or only for women with a particular risk. Also, they differ in the way reimbursement is considered for NIPT and which genetic conditions to screen for. One important challenge with respect to NIPT is that its desirable scope and purpose can be conceptualized in many different ways, and sometimes also contradictory ways. It can be seen as a technology that helps preventing the birth of children with genetic abnormalities, or a technology that is able to enhance reproductive autonomy of the parent, often the mother. These different views do not only lead to conflicts between stakeholders, but also to contradictory statements or conclusions between different components of an assessment. Economic analysis of NIPT make use of outcome measures such as cost per additional abnormality detected or cost saving per disabled child not born, which frames NIPT as a technology that becomes more cost-effective when it prevents a sufficient number of births affected by genetic disability. This may suggest a purpose of NIPT that conflicts with the desirable purpose which is suggested by social and ethical analysis. This fragmented and potentially conflicting assessment of different types of impact of NIPT puts decision makers in a very challenging situation. Therefore, it would be highly relevant to be able to conduct an integrative assessment in which the clinical, economic, social, and ethical aspects of NIPT are comprehensively assessed in one way. And therefore, we have designed the Validate approach. The starting point of Validate is that each type of impact, so the consequence of a health technology, have both an empirical and a normative or value dimension. And safety refers to the sort of outcomes that we wish to realize or to avoid because we have commitments to avoid harm. And then principle of non-maleficence. Clinical effectiveness refers to the benefits obtained in clinical practice. And are the sort of outcomes that we wish to achieve because we are committed to do good, the principle of beneficence. For example, we want to prolong life, we want to restore functioning, etc. Finally, cost effectiveness refers to the sort of outcomes that we wish to achieve because of our commitments to the distributive justice of fairness. For example, we want to provide technologies that are proportional between resource commitment and the reduction in burden of illness, or, for example, to ensure equitable access to healthcare. So it means that ethical questions concerning the desirability of a health technology are guided by the normative or underlying value dimension. And therefore, the questions about the desirability of a health technology will also guide how we actually will design the assessment of an HTA. So the main components of Validate are normative distinction, are an integral part of HTA, and very important that stakeholders can have different views on what is desirable and not desirable. And this needs to be taken into account when you conduct an integrated assessment of health technology. So how can we do this? So in every empirical inquiry or HTA, the following question need to be addressed. So what sort of things matter to us and for what reason? What sort of things may happen when we would like to start using the technology, and also what sort of things can we obtain reliable knowledge about. In other words, HTA is not a matter of collecting the facts, but a matter of collecting facts that are considered to be relevant which consequences are desirable or need to be avoided in view of values to which we are committed, whether these facts are plausible, what consequences can be plausibly associated with the use of a technology in a specific context, but also which are indeed best or which consequences can be studied by methods of inquiry that are held to produce reliable knowledge and understanding. So in general, it consists of collecting claims and concerns by stakeholders that have been expressed in the literature, on website or interviews with stakeholders regarding a specific technology, and also explore their initial credibility and relevance. This actually helps determining a relevant and meaningful scope of the assessment. Here is the example of NIPT again. So here you can see that one important challenge with respect to NIPT is that its desirable scope and the purpose can be conceptualized in many and sometimes contradictory ways, which you can see on this slide. So what is what we want to realize or avoid by using NIPT? And this can be detecting genetic abnormalities. It can be to prevent the birth of children with genetic abnormalities, or facilitate informed choice, or enhance reproductive autonomy. This is very important. These views do not only lead to conflicts between stakeholders, but also to contradictory statements, conclusions between different components of an assessment. So the identification of views can be done via scientific literature, website, and interviews with key informants, and also shows clearly the different views, what makes NIPT valuable, and how these might conflict. So what the relevant facts are depends thus on how we regard the desirable or undesirable effects of a health technology. So if we look at NIPT, we, for example, want to collect data if we think that the desirable effects of introducing NIPT is detecting genetic abnormalities. For example, trisomy 13, 18, or 21. Then the empirical research to conduct will focus on mainly the diagnostic accuracy of the test. And here you can see that we have listed sensitivity, specificity, positive predictive value of NIPT for these conditions. If we want to facilitate informed choice, then we might want to focus on other questions, like do parents experience that they were well informed, was there an informed consent procedure, and was the choice voluntary? And for this type of questions, we need other types of data and also other types of research, more qualitative research. So this is very important point to note. Like I said, the context and the different stakeholders matters. It also matters from stakeholder to stakeholder. Depends on whether you are a mother or father, if you take the perspective of the unborn child, or people living with a trisomy, or the clinician, or the decision maker. But also it may differ by context. For example, in the Netherlands, NIPT was assessed to determine whether it could contribute to improve prenatal screening by providing respective parents with meaningful reproductive choices. And this was defined as making a choice about severe health problems in an informed way and being proportional, that is, respective of the autonomy rights of the child. In Germany, NIPT is defined as a medical procedure that is meant to be the ability to save a healthy fetus from procedure-related miscarriage. And this actually was highly contested by different stakeholders in the country. But here you can see that what or how different contexts perceive the desirability of introducing a technology can also differ per country or per setting. This is another example, which I will not go into much detail because of the time, but there are other technologies that we have assessed, which clearly shows that there is a difference in how different stakeholders perceive the problem definition or the desirable effects of addressing a problem. In this case, it is whether or not to use cochlear implants for prelingually deaf children. And here you can see that those that are in favor of cochlear implants, CI on this slide, really felt that the problem was that deaf children can't hear, while those that were against cochlear implants, which was especially the deaf community, felt that sign language was more the solution to this problem than cochlear implants. So this is something very important to note and might, as you can imagine, also impact the uptake of cochlear implants in a certain community. Another example is the use of digital technology to resolve current capacity constraints in mental health care. Also, in this case, we clearly saw that there were different views on whether or not digital health could be a potential solution or actually what the problem was that we try to solve with the use of digital technology. And therefore, the use of Validate could be very helpful in determining how you would actually design such an assessment in real practice. Here, we clearly show that there are different potential uses of digital technologies and that there might be alternative options to be used in practice. For example, open dialogue approach, natural language processing that also could potentially help capacity constraints in mental health care. So what are the implications for health technology assessment? So assessing health technology requires making normative decisions on how potential value should be conceptualized very explicit. And this actually guides the identification of relevant evidence that you might not have thought about when you only take one perspective. And therefore, it's very important to include different stakeholders in your assessment and also show that ethics is an integral part of every type of analysis. So the added value is actually to understand the problem and values from each stakeholder perspective, often brings to bear that there are different perspectives on the problem. That's very important for an explicit scoping of your assessment, and also that you really would put your efforts in defining the correct problem and the potential solution. So actually it is about how to avoid giving the right answers to the wrong questions. And therefore there is a need for such an integrated assessment. So I would like to thank you for your attention, and I wish you a very fruitful discussion after all the presentation. Thank you so much, and warmest regards from the Netherlands.
I thank you also for this session, ladies and gentlemen. This session was a bit different. It was a hybrid session. We have so many new solutions after the pandemic. If you have any questions, please forward them to me. And I invite you to the last session, the value of healthcare, the patient perspective. We will have that session after the lunch. I encourage you to join us. Thank you.